All right, hello everybody. Welcome back for what I think is going to be a very interesting session. We have an incredible panel which is going to discuss addressing health disparities with digital solutions. And leading the panel is Jim Short, who I hand it over to you now.
Yes, so good morning, good day, good afternoon to everyone. Thank you very much for joining our session. And thank you, JP, for getting us started. So I'm Jim Short. I'm at the Supercomputer Center at the UC San Diego. I run a research center and a laboratory at the center. And today we're looking at a topic that is obviously one well discussed and really an international topic, which is looking at health disparities and the relationship of digital and digital solutions to those disparities. There is a lot of anecdotal discussions, there's policy discussions, and I don't need to add, as we encounter AI, many people are asking whether AI will help or exacerbate inequities in health, largely in distribution and in different areas, which we will discuss today. So it's a pleasure to introduce really a panel of experts who have presented both nationally and internationally on this topic. Everyone knows this panel, everyone knows each other and works together. So those of you who want to ask questions can ask anyone on the panel, and we may jump in and answer as a team, since that is our work environment for many years. So our first speaker is Dr. Scott Kahn. Dr. Kahn is a noted expert in many different areas, but his particular focus on this topic has been looking at the difference between institutional and personal control of privacy and how digital elements are affecting privacy and inequity. And Scott will explain kind of his perspective on that. And Scott also carries extensive experience in the information area. He was this long-serving CIO, now retired from the company here, Illumina. Second speaker is Professor Tim Mackey. Tim Mackey is on the faculty at UCSD and is an expert, noted authority on global health policy and health policy in general. Tim has presented and been called before Congress to talk about different areas of expertise. He's joining us today from Japan, where he is. So Tim, thank you for, I think it's about midnight there. So we appreciate you coming in from Japan, where you're doing some work there with some Japanese authorities. Our third speaker is Dr. Ilya Zatlowski, a colleague of mine at the Supercomputer Center. Ilya carries many hats. He'll smile when I say this. His primary focus has been on geospatial information systems. He runs a lab in that space. But he's really a guy that studies visual information mapping with many different techniques that are appropriate to that. And as Ilya has been recently voted the top data scientist at SDSC, and he is a gifted experimentalist. I'm sorry, Ilya, I needed to put that in, and he has 2 PhDs. So he outranks all of us in the number of years to accomplish those. This is a group with extensive educational background as well as some practical experience. Our cleanup speaker, batting in the batting order, is Dr. Peter Deland here. Peter has many hats, including a PhD degree in semantics, which we talk about at different points. Particularly in some of the topics that have been discussed here today and yesterday, for those of you who've been tuning into different sessions. A lot of what I'm hearing on people's product catalogs and so forth and so on. For those of you on the technical side, you know that a lot of this has been discussed in the field of semantics for many years. And it's interesting to hear it again in its different forms of applications. Peter is also, in addition to his academic experience, is a startup guy, an investor guy, and was a founding part of the founding team at Calibra, which is a sponsor to this event. He's currently at a startup, since that is the cycle, at a Boston-based health company, which he'll explain, called One Up Health. So, gentlemen, let's get started. It's a real pleasure. Thank you all for joining. And Scott, I will turn to you.
Great, thank you, Jim. Let me just get my screen. And Jim, just confirm that that's coming through fine.
It looks great.
Wonderful. So thanks, and thanks everyone for joining. As the leadoff batter here, I need to get on base, and so I really wanted to frame things up into our take on the topic. I think that the thesis of my part is that a lot of the inequities that exist, not all, are due in significant part to just non-inclusiveness, that the people aren't involved in the clinical research, and so they're not represented. And as a consequence, medicines aren't always as useful for them as they need to be. This can be related directly to a lack of trust that I would say has been earned. And that, surprisingly, if you take a fresh look at data privacy, it's actually a solution. It's not a problem. It's not making a problem, but it's solving a problem. So let me get started. I think when you consider why individuals don't participate in clinical research, part of it is from a country basis. It's that some regions of the world want to have their populations and their data of these populations kept to them, and it's out of fear, potential fear that something might be done to harm them in a very localized in-country way. Second consideration is that from an individual standpoint, there are lots of examples, and I won't go through them. I've noted a couple here where I'd say that the medical and academic establishments that's been doing research with health data has done things that you might find to be inappropriate. Tuskegee is probably the best one, but there are many others. And this is in large part why I took the view to understand how data protection laws and data privacy might be a solution to the problem. As I said, the lack of representation often causes these inequities. There's probably a paper in the literature every month that outlines how medical treatments are different for different ethnic backgrounds. This is just the reality of how your genetics affects your ability to respond to treatments. And you might say even people that are included could benefit from having more contrast, because if you don't have contrast, you actually don't understand the totality of the problem. And this gives rise to treatments that aren't comprehensive. This whole issue of trust, I'd say, is very easy to cite and very difficult to address. Over the last 4 or 5 years, a number of groups have really outlined how this affects communities, how this affects individuals. A group at Baylor Medical had looked at something through a medical information commons that they had talked about. The World Economic Forum has had a lot to say in this area, and most recently, the National Academy of Medicine has. And it's interesting, everyone says establish trust, get patient engagement, but then they don't provide the solution. It's just left there hanging as something that we need to figure out. And I always like to point out that when I talk about data privacy, it's distinct from security. That security I always see as the foundation that you absolutely need, but that data privacy are really the policies that you build on top of that foundation. And so my simple example here is there's a lot of data that you're able to access that is extremely secure. And once you're given access to it, as I show it, the data is kind of out in the wild. And that poses a problem if you ever wanted to correct your data, pull your data back what have you. And that when I talk about privacy, I talk about a closed system, and just we need to explore whether you can do the types of research that you need to do within that closed system, but that it stays under the policies of privacy that you establish, so that when people join, they know that they always have the ability to control their data. And this is greatly empowering, or at least that's been our experience, that if you abide by giving individuals control over their data throughout the process, that one, they're very willing to participate, and two, they're quite satisfied with that sort of arrangement, because they know that if any time you violate their trust, they can take their data back. So fortunately, this is an area that I've been working in for the last 5 or 6 years. And I wanted to start off by saying it's always wise when you want to try to solve these problems, especially when you're talking about an issue of trust, to take some time just to listen, either to the individual that you're trying to help or the community that you're trying to help. And this is going to be discussed further in the second presentation, but I think it's quite relevant that even when it comes to dealing with rare disease, talk to the individuals that are affected, or the parents of the individuals that are affected, see what is most important to them, and then guide your treatments and your interventions to address those needs, rather than just saying, oh, we're going to try to address it from our perspective of the disease. Listening is always a good place to start. And I know that's the kind of thing that you probably tell to your kids. It's equally true when you talk about the use of people's data that they're sharing with you. Kind of ask them what they want, what are their expectations, and then ultimately deliver on that. The system, the platform that we had put together is one that's called Luna DNA. And the inspiration was really, we wanted to try to find a way to empower individuals to share their data, to do it in a way that industry or academia could use it to make new discoveries, and that ultimately we'd be able to connect these groups in ways that were both satisfying to individuals and productive to industry. What we found is that if you use privacy as your basis, that you can deal with data that is essentially borderless, because around the world, people are able to control their data. So if they want to put it into your sharing platform, they can. You can collect it, it can be longitudinal, and it ultimately is controlled by the community. So, and the community is defined by the group. It could be a registry, it could be a societal community, it could be just an interest group. We see that as being really important. On the industry side, on the research side, think of it as ideal data that's been pre-assembled and longitudinal. It's kind of the perfect data that you ultimately like to work with. We deal with the notion of e-consent, so that you can incrementally consent people to inform them when they have the ability to understand what you're asking for. And that ultimately this creates a system that people participate and they don't leave. They have the option to leave, but our experience is they don't leave. I wanted to just give a sense, lunadna.com is a very small company. We do no marketing, but what we found is that people are attracted to this notion of having their data shared, but under a privacy framework. This was a couple of years ago, and I just went through and I wanted to show, you can see over the course, we have enormous growth around the world. Right now we have over 180 countries represented. Yes, you'll notice that the English-speaking countries tend to get on board first, if you will, but most of all of Europe, Western Europe, is participating in it. It's remarkable that if you share data in a mechanism that is giving them control, they're very willing to do it. Yes, Germans have been able to put data into the system from day one. So even though I know the data adequacy decision that was just granted is new, it didn't apply to us because individuals were making these decisions. So where I wanted to leave and pass off to Tim was simply to say that if you really think about the role that privacy could play, and if you implement it, that you can create an environment where rights-based or privacy, such as something like GDPR in Europe, does provide a connection between individuals trusting, participating, and being engaged. That net overall, we see great participation by minorities or people that are underrepresented. And this is simply because they have control of their data. So it's never used for something that they would find inappropriate. We see that non-compliance with data privacy really is a limiting factor. So it's like, just step up to the bar, understand that it is an enabler, and embrace it. And then lastly, we believe, and this is our experience, that it is an enabler to get more inclusive and more representative participation in clinical research. And we see this as a path to ultimately having medicines that are developed for everyone. So with that, I'm going to pass the ball. Let me just stop share to Tim. Thank you very much.
Scott, thank you. We'll have some time to explore several of the topic areas you've raised, specifically on different types of personal and institutional control of data, which is a kind of a key piece of this notion of research and releasing it, and the point you made about data once released is in the wild, and the concept of how, whether, and is it possible to actually pull that data back. So onward, Tim, let me just share a screen and set you up. Everything good? And let me just get that coming through. Is that coming through?
Jim, can you see my screen okay?
Well, I'm driving slides. So is that, so are we okay?
I think I have control of the slides and I should be good.
Oh, all right. Very good. Then carry on.
Cool. Great. Sounds good. So first want to thank CDOIQ for the opportunity to do this discussion and talk about a very important issue that's dear to my heart, and something that Scott really did a great job of introducing. And I'm going to just follow up on some of the discussion points that he was introducing, particularly around clinical trials and particularly around the use of data in applied health informatics. So we'll be talking specifically about the use of interdisciplinary data science and co-design approaches to address health equity and provide 2 research case studies. Real quickly, as a disclosure, I'm also the co-owner of a startup company funded by the NIH, which also has several federal contracts and grants. In addition, one of the projects that I'll be discussing here today was funded by the FDA, so we need to provide this disclosure statement that the contents of this presentation don't represent that of the US government or FDA. So getting that out of the way, as kind of Scott was already mentioning, one of my central hypotheses is about listening to people when we're doing health equity projects. And when it comes to health equity and particular vulnerable populations, you have to start with listening first. And what we're trying to do is develop different tools to help people, 1, enroll in clinical trials, and 2, share and manage their genomic data through a blockchain. And all of these projects are funded by different funders, whether they be the FDA, whether they be for our blockchain project, the Robert Wood Johnson Foundation. We start with interacting with the community of interest and starting to design tools from the start with their perspectives, needs, and opinions in mind at first. So you can't really skip that process. So for this first project I'm going to discuss, we have a contract with the FDA to develop co-creation of digital tools to enhance young adult minority participation in COVID-19 trials. And the reason to do this is because, young people are essentially the future of clinical trials, but their interests and needs are very different when it comes to their engagement with science And the COVID-19 pandemic has really changed the dynamics around how young people interact with, scientific participation. And yet we don't know what the full impact of COVID-19 is on people's perceptions, attitudes, and behaviors towards, for example, clinical trials, especially given that many people may be vaccine hesitant. So what we did for this project is we first did something that Ilya will be covering, which is geospatial analysis. We wanted to understand the built-in environment of where were clinical trials happening in the United States, and were they happening in communities where there are higher percentages of minority populations, people who don't have access to trials, people who may be impacted by health equity issues like socioeconomic determinants of health. And we wanted to know, again, what is that data layer and what does that environment look like when it comes to people actually accessing clinical trials? And so with that data, of course, we pulled this from clinicaltrials.gov. It's a publicly available data set. And we also were able to look at it more specifically within areas like Los Angeles and other parts of Southern California in large metropolitan areas, because a lot of the geospatial information there and correlates associated with access can be different. So what COVID-19 also taught us was a lot of public health is very local. So building this map and understanding where those trials are located was the first part of this project. The second part of this project involves social listening. And what social listening is essentially looking for people discussing in an open fashion from publicly available data on social media and different platforms, their attitudes, behaviors, and opinions about their experiences with clinical trials. So one platform we looked at was Quora, and Quora told us essentially, what people were questioning about clinical trials, what they wanted to know about trials before they joined them. And specifically for COVID, what were their concerns about trials? So with this approach, this is a rapid dashboard we built for FDA. We were able to identify some certain themes associated with why people may or may not be joining a clinical trial. And you can think of this as like a large scale focus group, but essentially it's giving us some information that we need from publicly available sources to start identifying barriers and challenges associated with clinical trial participation in a more real-time approach, because faster than surveys and again, a way to identify what people are saying at any given time. But then really what we talked about before is we wanted to really talk to people about their experiences with clinical trials. So we ran a focus groups with young adult minorities at a minority serving institution. And they told us, exactly what they thought about clinical trials and why or why not they may not join a COVID-19 trial. And as you can see on the right, a lot of times the reasons why people may or may not join a clinical trial are going to be different depending on that data source. And we also showed them the map of the clinical trials located nearby them. A lot of them were, of course, unaware that any clinical trials were going on, and that also impacted their interest in joining a clinical trial. Some of them were upset that, for example, that trial information wasn't more actively communicated to them. And so a lot of these lessons that we learned are very important and can be stratified also among certain minority groups. So certain minority groups reacted certain ways, certain others had different opinions, and a lot of that also coming from historical injustices associated with these trials, with perception about what clinical trials are and how the government has administered them. So from there, we did a co-design process where we actually talked to another set of young adult minorities and asked them about what type of tools they would want to engage in a clinical trial. And so this is a picture from some of the some of the brainstorming we were doing with them, some of the co-design, and it ended up in a trial match tool that we've developed as a mobile app. And we're consistently, even going back now, talking to new focus groups and asking them if this is the type of app that they actually want to use and develop, and we're refining that tool over time. So it's both a mobile app and a web-based app. And so even, again, before the design process even started, we began to look at the built-in environment, at the environment of where clinical trials are. We then did social listening to understand what people were saying in public forums. And then third, we did focus groups to understand what people's lived experiences were. And then we started building the app after that. So a lot of developers may start with, well, we have an idea. We know that we need to enroll people in clinical trials of minority groups, but they don't start by looking at all the different data that's available to address that and trying to triangulate that around a solution and a design framework that makes sense for a particular population. So this last one I'll talk about is using the same similar approach, but addressing it from the lens of blockchain as a technology type, and then also addressing it from this concept of indigenous data sovereignty, where indigenous peoples have their own legal and cultural and respected rights to data different than other non-indigenous groups. And it starts with the concept that that data is sovereign to them and they own it, and they should be actively involved in the process of managing it and sharing it. So here, a very similar concept. We wanted to conceptualize what a blockchain approach would look like to address or to further indigenous data sovereignty. And then second, we wanted to partner with a community partner at the Cheyenne River Sioux tribe called the Native Biodata Consortium, who have their own genomic sequencing machines on their property and are involved in the collection of genomic data. So we developed a proof of concept of the blockchain itself, but that was also in consultation with the tribe and also with a community advisory board. And we're in the process of evaluating that kind of in real world settings. So again, similar to the last research example, it starts with engaging with the community first. It starts with talking about what is a blockchain, what is the purpose of the blockchain, or what do you think the purpose of the blockchain should be? What are the technical aspects of the governance of the blockchain that map to this concept of indigenous data sovereignty? And then third, how do different stakeholders want to use it? And each tribe could have different reasons to use it. It could be related to the type of data that's being collected. We're focused on genomic data. And then you get into kind of what are the different application layers we can use to try to address, privacy. It could be privacy, it could be data sharing, it could be benefits. All these things have to kind of be pre-negotiated with the community of interest. So we've done a number of brainstorming activities, including at conferences that are specific to indigenous populations. We also have a community advisory board. And we also have a number of different areas where we're reaching out to the community partner and BDC and making sure that our interview guides and all types of things that we're doing is aligned with their mission and objectives and represents the interests of their community. So if you're curious a little bit more about the technical aspects, there's a paper published in Cell that gives you an example of the general framework of what that blockchain would look like for genomic data sharing. And again, this project's ongoing, but we're involved in the process of doing key informant interviews, and that will help us design the blockchain environment. And then we're hoping it's modular enough that different tribal nations can then use it as they want for their own individual purposes for different sharing of health data. So my major takeaways here are just that, a host of data science methods are available to advance health equity goals, but they really have to be done in partnership and consultation with the community of interest, especially when it comes to any type of health equity project. And we believe that co-design approaches are really the most effective way to do it. You learn a lot by talking to people and designing things in a way that is responsive to what their actual needs are. And there's a lot of ways to do co-design approaches, but we take the process of triangulating data from multiple sources, building a prototype, and then iterating on that prototype with a group of people who that tool will actually impact. And oftentimes, communities aren't actually concerned about the specific technology used. They're really focused on how those solutions will address barriers and challenges. And ensuring design that's inclusive of these viewpoints is extremely important. So with that, I'll hand it over to Jim for our next speaker. Thanks.
Tim, thank you very much, Tim. And I just want to add that both Tim and Scott have worked on different elements of the underlying blockchain architecture. That is part of what Tim's project that he just explained has implemented. So as I mentioned at the very beginning, this is a group that works together. So we have that as a dialogue in the question and answer if you guys are interested in that attending. It's a pleasure to reintroduce Dr. Zaslavsky, colleague at SDSC. Over to you.
Hello, and thank you for the opportunity to share some thoughts on the technical challenges in analysis of vulnerable populations. So I work at SDSC and run Spatial Information Systems Lab, mostly funded by the National Science Foundation and the NIH, on multiple projects, not necessarily related to healthcare and public health. And I also teach spatial data science in the UCSD data science program. So I'm in academia, but the types of data and infrastructure issues that we deal with are very similar to the challenges faced by information officers in the commercial world. Many of them were discussed at the conference yesterday and earlier today. And also very similarly, the main issue is maximizing the value of the data. Also, the concept of value in academia is a bit different. At a very general level, it's done by making data collection protocols more reliable and transparent, improving data and metadata quality. And we've run several projects that showed how it could be done at scale. By making sure the data are managed in a secure way and personally identifiable information is protected, by following community standards and APIs to make sure that the data are interoperable. There are a number of other common issues. They are quite well known. I'd say that the COVID-19 pandemic really amplified these challenges because we've dealt with an unprecedented amount of data, tracking positive cases, deaths, recoveries, and vaccinations, social determinants of health, the data coming from a large variety of sources, including hospitals, local governments, international organizations. The quality was very problematic, especially at the beginning of the pandemic, and making it more challenging. Vulnerable populations or populations with higher risk of negative health outcomes are often underrepresented data collection on testing, use of medical services, vaccination, and so on, leading to systemic bias, as Scott and team talked about before me. Some lessons we have learned, and these are the main points I emphasize, the need for a deployment-ready system of tools that can be used at the time of crisis, customizable for specific health emergencies, the need for authoritative, transparent, and easy-to-use decision support tools, because this is critical at the time of uncertainty. And what we also found is that technical challenges are solvable. The issues that are much more difficult are related to privacy and ethics, stakeholder engagement, co-design, sustainability, trust, how you define your users, how the data is governed, public acceptance and social impacts, and generally better understanding of the community that you work with. I will show you several illustrations of these issues from recent pandemic-related projects in my lab, related to spatial analysis, modeling of infection spreads, decision support tools, and mapping the research community. So mapping vulnerable communities based on multiple risk factors is probably the most common technique, and Tim already showed one example of its use. Here is an example of an online system where you can map any risk variable, such as percent of people in poor health, or select any combination of risk factors to zero in on the most problematic areas in San Diego. For example, find areas that have a high proportion of people without health insurance, have asthma, lung disease, high level of obesity, as the next variable will show, other risk factors. This app is quite easy to use, and it allows decision makers to experiment with risk factors and derive their own definitions in a transparent manner. And by the way, what I'm showing is a free online software called SWAF, which stands for Survey Analysis with Visual Exploration. It is developed in our lab, and it's been used in multiple domains to publish, analyze surveys and image collections. To get visualization like this, the key issue is organizing data in a consistent spatial temporal framework, in this case by census tract, so that the data can be easily explored and used to identify vulnerable groups and areas where they Another project where we ran into somewhat unexpected non-technical issues. This is an agent-based model of COVID transmission in schools built over floor plans of real schools, simulating different classroom activities and computing infection risks under different interventions. I cannot tell you which school it is here, but this is a floor plan of a real elementary school in downtown San Diego. This was an initial view showing how almost everybody will eventually get infected if no adjustments would be made. That is, no mask, lunch remains in the school cafeteria, same level of attendance, ventilation is not adjusted, and so on. And then we simulated different interventions to see which combinations would work better given resources and circumstances of each school and the types of students that individual school has. Then the same model applied to school buses to look at relative risks of infection in different parts of the bus. San Diego School District allowed us to measure internal dimensions of several bus types and even ran an experiment. You can see on the video that in a moving bus, airflows are from the back of the bus to the front, which obviously made bus drivers very anxious about the risk of getting infected. So we computed a range of such models for the school district, but what we didn't anticipate was some interesting ethical implications. While we can use CFD models to compute risk in different sections of a school bus or in a classroom, given its HVAC configuration, this information may be very difficult for school administrators to act upon because they would make decisions about which students to sit in relatively high-risk areas. Fortunately, in this case, the differences in risk levels are small enough to ignore, but it would generally pose difficult ethical questions. It was an interesting lesson about the need to think through potential ethical concerns from the beginning. Another example is from our work with San Diego County Office of Education, so-called e-decision tree, an online system to generate guidance to students and school staff about how long they should isolate at home, if infected or exposed to the virus, when they should get tested before coming back, based on information about symptoms, test results, or exposure circumstances. It was based on CDC and CDPH guidelines and initially intended as a tool for school administrators and nurses. But what happened at the beginning of last year, in January, Omicron was in full swing and schools simply did not have enough personnel to do contact tracing for their own staff, much less for students, because so many teachers and administrators were out sick. So schools and school districts mailed to parents asking to go to our website and use this tool themselves. Suddenly, the model of our customers changed drastically. So we had to go through multiple iterations of adjusting the application to make it work for parents who of course have very different experiences, internet capabilities, and attitudes towards COVID. And as to attitudes, we did get some very interesting feedback from COVID deniers as part of this application. We all know that it's an important practice to precisely identify your customers, but when there's a health crisis, be prepared that your customers may change. And my last illustration is about the importance of understanding your community. Here is the same application that I mentioned before, the SWAV, but with a view we added recently, which allows you to analyze co-authorship networks. Here, for example, we have authors of all publications that mention GIS, vulnerability, and climate change in titles or abstracts. And we can see how they're connected with each other. We can zoom into specific researchers. We can also see how it developed over time. When I move the slider and then move it back to 2023, you can see that there were, how the clusters grew, and we can also see individual characteristics of people in terms of their location in the network, such as centrality, clustering and other characteristics. You can also look at distributions. Here is everybody in several of the most, countries with most authors, and for any of them, you can get publications on this topic. So this is a way to, I'm showing this because very often academic community is a bit opaque to the commercial world and the other way around. So this is a way to explore and understand the essential connections in a given domain, identify potential partners, see which topics are trending, how research clusters get formed, who are the key players, and so on. And finally, the slides, a slide about my lab and some projects we've worked on, and my contact info. If you are curious, please get in touch. Thank you.
All right, very good. Let me just draw a couple of connection points here before we go to Peter Dieland here. So the connection point for those attending are that we started at a policy level, and Scott identified a number of different drivers and a particular architecture that is being used in the Luna environment. And you saw that we'll carry that discussion on, and Scott will come back in the Q&A session to explore that. Tim then looked at a very specific set of policy directives and included in that discussion reference to a blockchain technology that he is pursuing with respect to the privacy elements of indigenous health research activities, which connects to Scott's presentation on the actual field level investigation that has a policy implication for bringing in and addressing health inequities and disparities in health treatment and health distribution. Ilya has brought in another set of tools, which is looking at geospatial information and using that as a tool set in a variety of different decision contexts, all of which look at representational systems and to visualize that. And I just want to make the connection to earlier sessions in CDOIQ, where it has been the connection point being that when people have discussed what your data analytics group is doing and what is the tool sets that are available in the data analytics toolkit that then looks at different decision contexts with policy implications for the either government agency or the corporate organization, this is the flow that we wanted to set up at this session. I'd like to now reintroduce Dr. Dieland here, who's looked at this both from a targeted point of view with the Calibra organization, which he helped found, which identified catalogs, which came up this morning in the discussion with Brian Erickson, Captain Erickson, and with USPTO CIO Jamie Holcomb, who talked a lot about establishing data catalogs in both the Coast Guard and the USPTO. So I just want to make that connection point. That's the flow, and we've been trying to track and to assist those of you who are also looking at these different sessions and make some connection points there. So with that introduction, I'd like to reintroduce Dr. Dieland here. Peter, over to you.
Thanks, Jim. I know we also want to do some Q&A, and I'm going to keep it short and sweet. First of all, I would like to thank you and the organization to invite me again. It's always wonderful to be in this community. And I also really enjoyed the talks of Tim and Ilya and Scott here. As usual, we've been part of this community that you started in San Diego for quite some time, and I always enjoy the progress you guys are making and the impact you're creating in these fascinating use cases of advanced technologies to drive really more equity in clinical trials and medicine in general. You bring in the concepts, well, to just extend what Jim said, right? Concepts of platform thinking, right, Scott, and community design, Tim, and blockchain, visualization, machine learning, to drive this much needed innovation, right? But I would like to really kind of shift our gear back to the basics, right? The US healthcare system, which most of us here are all a participant in, whether as a professional or as a member in most cases, right? And we are dealing with a US healthcare system that does not even have the foundation for data quality, governance, or cloud computing that enables payers, providers, ACOs, other members, other participants to just very easily exchange much needed basic health data. And when I'm talking about basic health data, I'm talking about clinical data and claims data, right? We talk a lot about that in other industries, right? This conference has been one of the main venues for this, right? And especially around the management aspects of quality cataloging, governance, etc. But for some reason, and for very known reasons now, health data still is something different than what you would think as data, right? It seems to be another new element in the table of Mendeleev that does not agree with much of the laws of nature we usually understand on how really data shapes and moves and gets utilized. I mean, if you go to Amazon and order something, you know, it takes you a few minutes. The day after it's delivered at your house, you don't have to care where it comes from. You don't have to care how it is transported to you. And you actually don't have to care how you have paid for it, right? If you look at the social media industry, advertising, online advertising, they are able to perfectly construct a real-time timeline of you, right? If you have a conversation about something, you will get advertisements just a few minutes later about that very topic. So, and the list goes on and on of industries who have now successfully brought storage and compute to the core of their business operations, but we haven't seen it in healthcare. And the US healthcare system is a $4 trillion system where at least 25% is overheads because of a lack of digitalization and a lack of usage of data. But on the other hand, we also see that the biggest growth in data in the world, more than 30% share, is in healthcare, right? So we have the biggest growth in data, but also the largest underutilization of data. And we see that, of course, there's a lot of breaks in the system. Healthcare professionals are frustrated with the system they have to interact with. And members like us have a difficult experience kind of finding the right doctor, finding their healthcare records, getting easy access to that, sharing it for other purposes, for example, also more advanced purposes like the ones illustrated here by our colleague panelists, right? Now, at OneUp Health, you know, we provide a cloud platform to store and compute health data with a very specific focus today on clinical and financial data, in order to then kind of bring that together so you get a full picture as a member, or that then drives more liquidity in the healthcare system that is worth $4 trillion, right? And we currently serve mostly payers, but given the regulatory tailwinds they had to really go digital and really expose claims data through RESTful APIs. It's also called a FIRE strategy. But we also, of course, serve others like ACOs, digital health companies, and even members who have their personal health applications who want to feed their health data into their app to combine it with other data, right? Today, we manage about 40 million American lives, right? We just got started, right? Only we raised 40 million in a Series C just recently. So I think we are really based here to really kind of disrupt this area. Now, of course, you know, you are all asking, how is this different, right? We have all these modern data stack technologies, but why doesn't it work for healthcare, or hasn't it worked so far, right? For me, there are like really three core tenets that needs to be driven in order to create value as a data platform, right? And in healthcare, it's not very different. The first is currency. The second is quality or equity. And the third one is liquidity, right? If you have a clear currency, in our case, there are a couple of healthcare standards that define the currency with FHIR first. And then, of course, open technologies that really provide a currency that then really kind of enables the measurements of your data quality. And, you know, we always talk a lot about data quality, but identifying data quality problems, the ability to measure is one thing, right? We are making a lot of good advances in that area now today with data contracts and more data observability. But on the other hand, remediation remains a very hard problem to solve. And particularly in the healthcare industry, where, you know, the data is often received from a monolith system where you don't really get access to the data steward who actually owns the data, right? Who enters the data. So that upstream insights to go and remediate data quality to then feed downstream higher quality data is still a big challenge, right? Now, if you get your quality right, you know, you provide trust and utility to the data, right? Because quality is not just a measure of the actual quality of the data, it also tells you something about the provenance and the lineage, which really drives that trust that Tim and Scott have been talking about, right? If some AI is going to use my data, I need to know how and in what respect, right? And a data platform should cover all these elements. Now, I don't even get to start talking about patient matching or entity resolution, which is very important in the space as well to drive the quality of the data. But then, of course, it brings us also to governance, right? And we all know the challenges of governance, data quality, lineage, observability, but I think we never really fully grasp them in an inter-organizational setting, right? I mean, the Colibras and of the world do that mostly intra-company, right, for very large organizations even. But once you're starting to consider governance and data sharing across an ecosystem of loosely coupled participants who have, of course, HIPAA-defined business associations among them so they can share your data easily. But on the other hand, we also need to kind of start finding ways of dynamically discovering opportunities for data sharing, even when these written HIPAA contracts are not in place. So that is very hard, probably the hardest problem to solve on the long run, right? You can have the top quality data with the best APIs and zero copy, whatever offering of the data in a catalog. You still need to be able to kind of do that in an organizational setting. And that is for us the largest challenge on the long run to enable that. And then the final thing is, of course, once you have all that data in place, you make it available. Well, if you then just export the data into a file and go and put it in a different cluster or clouds, you totally lose all the hard work you have put into it. And of course, we see the industry also, maybe not healthcare so fast today, but we see in general other industries moving also to the zero copy principle, where you leave the data where it is and you kind of really bring the algorithms or the codes to the data to do the computation. Because when you have zero copy, of course, you minimize your risk of having to transport the data or the costs of the networking involved with that. So it's kind of in a summary what I wanted to tell you. And Jim, I want to hand it back to you, and maybe we'll have some questions.
Thank you, Peter. I think you've raised the important point of the question of how we extend to, as you just identified, loosely coupled health complexity in the organizational setting, and how you deal in a loosely coupled decentralized system to try to encourage platform and sharing of data. So thank you all very much. JP, let me throw this back to you. You've been monitoring, and also I know you have a few questions you'd like to ask the speakers. So over to you.
Sure. Yeah, thank you. Very interesting. I have to say, very, very interesting. So to the audience, remember, you can ask your questions on the Q&A tab in Hoover. As I was listening to the first talk, Dr. Khan, And there is something that that struck me. You said, or so maybe if paraphrase a little bit, that it's very important to empower people to manage their own data. That they need to be in control of, you know, where their data is going. And one thing that I have found somewhat lacking in general is the user experience for those people to control their data. So I'll give you an example, something that we all see. We go to a website, and if it's a European website, we get a pop-up that says, do you accept the cookies, all of them, reject them, blah, 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 blah. Nobody has any clue what that means, right? And so we're going to click on something. How are you guys thinking about the user experience? We want people to be in control of their data. That requires user experience that is accessible to, you know, the common person. How do we do that?
Yeah, the quick answer is that I mentioned incremental consent and that we use e-consent. And that is, you need to make the consent small enough and clear enough that anybody that sees it, one, can understand it and has the time to actually read the shortness of it. So what we do is the platform has a very short consent, and it just provides the opportunity for studies to either have study-specific consents, or as you are developing the study, to ask for additional permission. So it's very much building upon GDPR's tenet of minimization, only ask what you need and ask when you need it, because then people can evaluate what it is you're actually asking and how it will impact them.
Okay, Peter, I see your hand raised.
Yeah. So just quickly, you know, in the States, we have this concept in healthcare called prior auth, which is a very labor-intensive process to actually, I mean, where healthcare professionals are able to make a decision on your behalf in case you cannot make a decision in a situation of an urgent medical care, right? So all the things I spoke about, you know, at that moment, you don't want to be in a situation where you have to give consent, right? So I think that is also a very important example where data, I mean, can help really drive algorithms to automate a lot of those processes, right? But of course, still with humans in the loop. But prior auth is a very important example of that is really coming up.
I am so skeptical myself, because when you go to the doctor, right, and then you sign those forms, there are some forms about data, and they are 3 pages long. They are incomprehensible. And so I haven't seen some example of something that is so crisp that, you know, my parents can understand, my grandparents can understand. You see what I mean? Like, so not the follow-up questions, but more sort of something that personally I find interesting and difficult. I'm a banker, so user experience is front and center in a lot of things that we do. And in the space that you described, I do not see a lot of user experience focus. So maybe a point that I wanted to make more than a question. So another question that I would have is, do you see a country sort of leading in this space? Or I don't know, a region or a US state, or like where should we look for a model? Like, you know, we say, okay, these guys looks like they are the model for the future, and others sort of who want to follow, you know, pointing to that model. Do we see that?
So I look to the EU, and I would actually say that while they got the privacy part correct, with European health data space discussions that have been going on for whatever, 4 years, and they're probably still 3 years until they're going to be accepted, which is all about how do you deal with secondary research use of data.
Okay.
So I think they're getting it right, but the process is very long. So I actually can't point to a country that gets the privacy right and how research is addressed and how individuals will participate in that. That's my answer.
Okay. Anyone else have a thought on that? In the last minute we have.
Well, I think You know, this is my opinion, right? But I think Scott is right. Europe is definitely on the forefront of designing proactively policies, which are not always easy to implement, I know. But on the other hand, I think the United States is at the forefront today since the Cures Act, which is a bipartisan proposed way of now really digitalizing the healthcare space. You know, payers have no interest in doing that so far. But there is really an important trilemma there about cost, quality, and risk of healthcare that needs to be resolved, right? And you can only drive these feedback loops with better data that flows through the system. And that push that now creates markets where OneUp can play in is very important. And I think that is unique to the American government to really create markets to solve problems instead of creating policies to constrain markets. And on the other hand, I think HIPAA is a great instrument. It's just underutilized. You know, HIPAA, of course, drives airplanes full of faxes and papers, which this healthcare industry is still based on, $1 trillion a year, right? But it still has the mechanism that allows to share data at a very fine-grained level with professionals, members, etc., across the system. We just need to kind of elaborate more on that.
All right. Well, on that, unfortunately, we have to close the session. So I really want to thank everyone. This was fascinating. I feel I learned a lot. And to the audience, thank you very much. And stay tuned for the next session, which I think is in half an hour. I'm not quite sure, actually. I haven't looked at the schedule, but thank you very much, everyone.
Thank you so much.
Thank you.
Thank you.
Bye-bye.